Kimberly Richardson. I am 62 years old, and in 2013 I was diagnosed with granulosa cell tumor ovarian cancer, stage 3A. I was not genetically tested at the time, but several years later was genetically tested at RAD51C.
Right. My name is Maxine Gordon-Williams, and in 2021, I was diagnosed with 3B grade serous surgery. My tumor was tested, and it was found that I had I was BRCA1 positive, and yeah, I live in Louisiana.
I'm Cheryl Scott. I live in Fort Mill, South Carolina. I was not tested originally, even though I have a strong family history. Originally tested BRCA1. Eventually was diagnosed with ovarian cancer, stage 3C, and they found 27 tumors, but I don't have any ovaries. It'll be an interesting story.
And I'm Kevin Holcomb. I'm a GYN oncologist by trade. I'm the obstetrics and gynecology chair here at Long Island Jewish Hospital and North Shore University Hospital.
So what brought me basically to genetic testing was in 2020, I was diagnosed with a second cancer, triple positive breast cancer. And I was interested in finding out, was GCT, granulosa cell tumor from ovarian cancer, connected to that breast cancer? And at that time in 2020, which was completely different from 2013, genetic testing was a part of that diagnosis. So they were able to go back, find that slide of the tumor and tell me, was granulosa cell tumor connected to this breast cancer? So that's what literally brought me to genetic testing.
Yeah. And, when I had my diagnosis, in pretty rapid succession, I had to have surgery, and I had a complete debulking. And during that process, my tumor was tested, and, the doctor told me that I had a genetic mutation. And I remember thinking, gosh, that's kind of a relief, because we kind of know that there's something going on in me that isn't, maybe environmental, or isn't something that I've done, or isn't something that is just random, which sounds kind of weird, but it was kind of like, okay, so there's been enough research maybe around this that they know how to ultimately treat me. So I felt a little bit better knowing that I actually had a genetic mutation, which probably sounds weird, but it gave me a sense of relief. And, I kind of felt as though, okay, we know then what I have to do moving forward to make sure that my cancer doesn't recur. But I'm still sort of in the back of my mind thinking, what don't we know about this mutation? So I feel like as though I have to consistently make sure that I'm trying to stay as engaged and involved with it, but not letting it drive every single decision in my life. Yeah.
And with me, I relocated from upstate New York to South Carolina, and my doctor in Rochester never did genetic testing, even though my mother died of ovarian cancer at age 48, and my sister died of breast cancer at 41, and my GYN doctor in Rochester never tested me. But soon as I relocated, my current doctor, which is like, I don't like your family history. So she tested immediately, literally walked me to the lab, and sent me a registered letter that it was positive. And then we have to make some decisions.
Yeah, I think your stories are, your stories are more typical of what happens when people are diagnosed, and yours is very unique. One, your story starts earlier, at a time when our understanding of, the genetics of ovarian cancer wasn't as well described as by the time your diagnosis came around. You said something interesting that I found, I think is very true, but I think it's very unique that you feel this way, that you were glad to find that there was a cause to your ovarian cancer. I find a lot of patients are upset when they find out that they're carrying a mutation. I think that leads to a lot of feelings of guilt sometimes about, did I pass this to my children, even though this is something that clearly someone has no control over. But it turns out you're right. Not only having a cancer associated with a BRCA mutation actually confers a better outcome women with ovarian cancer that are due to these mutations actually do better. They're more sensitive to chemotherapy. And there are actually treatment options like PARP inhibitors and all these new things that have come around that have worked the best in women who have mutations. And so I wish I could have that response with more of my patients when they find out it's due to a mutation. I'm trying to let them know, but there are positive things about this, and now your family can go test, and there's cascade effect that can happen from this new knowledge.
With the my current gynecological doctor, once she told me, my daughter was in the room with me, and we immediately started thinking about my sister, that she was their favorite aunt, and Aunt Nettie, and they watched her, deteriorate in a year and a half. And I immediately just got one tear. I didn't go crazy, but just one tear thinking about my sister. And my daughter, sitting in the corner of the room, said, "Ma, you said the generational curse of cancer was going to end with you. You just didn't say how." And because she was 9 when I said that, and because she said that, I had to get myself together. And I said, "So what's next?" And I said, "Well, these are going quickly. I don't need anything down there." And but the decision of a prophylactic double mastectomy was a lot harder. But I was going to do everything I could not to get cancer, and still got diagnosed with ovarian cancer.
Yeah, I think I also thought about my mom in that moment, because I knew that she, her diagnosis, or, what her death certificate said she passed away from, was uterine cancer. And so I asked the doctor, "Well, do you think that my mom also had this genetic mutation?" And he said, "Well, at this point, there's probably no way to know." But I just remember thinking again, the doctor had said that there are all of these therapies that are beneficial, more beneficial, the PARP inhibitors that you mentioned, with this mutation. And so I sort of got some relief or peace thinking that, okay, there's a way forward, because I always wanted to know also what's next, in this journey, what is the next thing that I have to do to improve the outcome and make sure that I'm doing everything in my power to make sure that this cancer doesn't come back. So, yeah.
Yeah, for me, it was difficult because there's no family history of cancer. It's just me, the luck of the draw, so to speak. And so by the time I was diagnosed with breast cancer, and they talked about the genetic testing, and I sat down with a genetic counselor, she had no roadmap. She had no path to connect any dots for me. And so when I got my results back and it said variants of uncertain significance, it was just like a shrug, like, well, I guess thanks for doing the test, but it didn't tell me anything.
Yeah.
So, but I still, regardless of the fact that it didn't tell me anything important, I still think it's important to do, specifically for families where there is a hereditary cancer. And the disconnect, I think, sometimes happens between your primary or your OBGYN, because at that point, you're not even really dealing with an oncologist, right?
Yeah.
And so that language needs to be changed about what's important to know, but also create an agency for us learning about what to ask.
Right. Yeah.
This incorporation of genetic testing into clinical use really started with our ability to sequence DNA. And so everyone knows, DNA is sort of like the thing that determines what the proteins are that your body makes. And some of these proteins, they work by preventing cancer. They're working day and night to keep you from getting cancer. And if one of those genes gets knocked off, you have a higher chance of getting cancer. Now, most people who get cancer, those genes are not working. It's not that they were born with this gene, it was in their tumor. So Max, in your story, they were actually looking for a more tailored way to treat your cancer. They tested your cancer first, genetically. And they said, well, your cancer has a BRCA mutation. That doesn't mean you had a germline mutation. Your cancer could have just developed a mutation. So they then had to test you, your blood, not just your tumor, to find out this is something I was born with. That first diagnosis doesn't necessarily have an implication for your family, but the second one, it does. And so it's not always so straightforward. You can test somebody's DNA sequence and say, well, this causes cancer, this doesn't cause cancer, and then you get what Kimberly has. What if it's not normal, it's not the typical sequence, but we don't know if that sequence is enough to knock out the function of that protein. So maybe it doesn't work, or maybe it does work. That's a variant of unknown significance. So you don't know. You're right. The shrug you had is the appropriate response, because you say, well, I had a granulosa cell tumor. The mutation you have does increase your risk of ovarian cancer, but not typically that type. It does increase the risk of breast cancer, but typically they're triple negative. Yours is triple positive.
Exactly.
So then you're left wondering, is this related to my cancer? And so it isn't always straightforward. That's why it's important to sit down with if you can find a board certified genetic counselor, because it's not always so simple to explain these results.
After the BRCA1 was positive, I remember that my grandmother's first cousin had breast cancer, cousin Maddie. And she was, when I remember, I'm 68, so it was a long, long, long time ago. But then I started putting the pieces with, as soon as there was no hesitation, I want to be tested, because I'd seen 2 immediate family members die. And ovarian cancer for my mother was so late stage that she was diagnosed in November. Actually, it traveled to her brain. So she was complaining about headaches. And then, so they did an MRI. And at that time, in 1984, there was no MRI in Rochester, New York. I had to take her to Buffalo, to Millett Fillmore Hospital. And they saw this tumor. But because she, they don't know anything's going on here, they think that it's just a sinus tumor. They get in, they test it. It's just germinoma. It is an ovarian cancer. So, and then it was just downhill from there. So I think because I'd watched my mother and I watched my sister, I want to do everything I can to not harm my kids emotionally. I'm going to do what I can do. And that was my decision, immediate. And now, it's a conversation. But I do remember, and I think this is common in African American families, when you ask, what did she pass from? It was female. You've got to tell us a little bit more. Was it breast? Was it ovarian? Was it, but they would not specify. And so my family now, it's a conversation. Everyone talks about testing and annuals and everything. And I happen to be the advocate for that right now.
I had no knowledge prior to my diagnosis and for cancer that I had no conversations with my family about genetic testing and any of that sort of stuff. So I've had to be that advocate within my family now to encourage them. As I'd mentioned earlier, I encouraged my brother to get genetic testing, and he has 3 daughters. And they all got tested, and none of them, have the genetic mutation. But there was no way that I was not going to push them to try to do that. And so now it's on the forefront of my mind. And so I think about it even with, non-family members, right? So if I have a friend who, in their family history, there is cancer, I'm encouraging them to think about it more. But in my family, we really, other than my mother, there wasn't really a lot of people who had cancer. So it was just not on the forefront of my mind.
Yeah, for me, again, as I said, there was no family or hereditary history. And so when I start talking to my sisters, I'm the youngest of 4. And when I started talking to my sisters who are older than me about go to your primary and ask for this genetic testing because I have been diagnosed, your insurance will pick it up. What I got back was serious pushback, was, well, my primary says I don't need to do that. And so it was, well, who are you going to believe? You know what I'm saying? I'm your sister, and I'm the one with the cancer, but the doctor. And so when we talk about how people deal with information, medical information, right? That level of fear that comes in, and that level of calm that seems to take over when the doctor tells you, you ain't got to do that, right? And then they shut it all the way down. So I find that for me, in terms of my advocacy, I take that that emotional burden of I can't get that across to my own family. And I just spend that time doing advocacy for others.
Yeah. Yeah. I think my mom waited way too long. Like she had all sorts of symptoms and before she, saw the right doctor and started to get treatment. And, the whole family says, we should really have pushed her more to have gone and seen the right doctor and not gotten all of the misdiagnoses that she got. Because by the time she was diagnosed, it had spread and she, was gone within a few months. So that's always in the back of my mind. And my brothers and I talk about it all the time. It's like, Mom, she retired. She barely had 3 years to enjoy her retirement where she got this disease. And I think that she was telling us in her own way that she was not in a good place, but just was too afraid to find out the truth, which is a lot of what happens, not just in our community, but just across the board. People just don't want to know because it's that uncertainty.
Yeah, I think it's a fatalistic thing. A lot of people have this belief that a cancer is a death sentence, and they don't understand because we don't share information. To understand, 40% of Americans will develop a cancer during their lifetime. Most people in this country who develop cancer survive their cancers. And so if you can sort of get your family to understand that there's a power in the knowledge because it's attached to interventions that can make a difference. Because I'll be honest, if you tell me I'm at risk for developing a disease and tell me you have nothing to offer me to decrease the likelihood of it happening, push back the onset, make it a better experience, honestly, I don't know if I'd want to know. But if you tell me that I could, with that knowledge, potentially do something to prevent this from happening, I'd want to know.
Well, for me, I was heading into a second diagnosis. So I had to toughen up, right? This wasn't my first rodeo, as one would say, right? And so for me, the genetic testing procedure was perfunctory. I was like, okay, let's just do that, because the information I wanted to know was GCT, granulosa cell tumor, in that tumor in my breast. That's all I wanted to know at the time, right? So to that level of genetics, that's where my head was. I wasn't trying to find out about mutations. And so when the counselor who I felt at the time didn't really have as much information to give me, I was like, okay, toodaloon. I've got to go start scheduling infusions. So my head wasn't in that space about being afraid of the genetic testing. At that point, I had been 10 years into advocacy and I knew exactly what I needed to do, right? And I had more providers and researchers that I had been working with who guided me into what my questions needed to be. So my agency was different from the first diagnosis to the second one. So fear was not really my problem. But I also understood with genetic testing, it's like, how do we communicate that to the Black community? We do it by being able to say, well, you got your mama's eyes. You got your mama's nose. Why wouldn't you do a genetic test just to make sure you don't have a hereditary cancer as well?
Yeah, for sure. There was no fear on my part. Like I said, I felt very comfortable with what was being explained to me and what my path forward was. And so, quite honestly, I mean, they tested the tumor, after surgery. So they didn't tell me they were going to do that, right? They just sort of did it. So that was the first part of it. And then they obviously had to test me again. And then it was like, okay, well, the next step is you're going to speak to a genetic counselor. And she walked me through, what my options were. And then I was sort of able to make very quick decisions about it. I had super support from my husband and my family. And so they were like, yeah, you have to do this. It was kind of a no-brainer. And I know that's not an easy thing for everyone to do, but for me it was, because I needed to know as many facts as I could so that I could make an informed decision about the way that I was going to move forward. And to your point, I had just had such agency after I finally advocated for myself and got that second opinion, which led me down that path. Then it was like, let's go, so that was kind of my outlook.
There wasn't fear, but there was mourning. And it wasn't mourning like I was going to die, but it was mourning that I have this that, God forbid, I pass on to my children, and I don't want to have the same outcome as my mother and my sister. So it wasn't fear. It was just like, I don't want to hurt my kids, so I'm going to do whatever it takes. I welcome the answer, because then you're right. Then we can know what we're going to do next for, the next steps. But was, it wasn't fear. It was, okay, let's go.
I hear this commonly in my practice, these multiple fears. One is the fear of knowing, almost like if I don't find out about it, I don't have it. And I try to explain to people, I say, if you have this mutation, you had this mutation from conception. You had this mutation from before you were born, and you'll have it tomorrow. And you had it for the last 20 years without knowing. And so trying to get somebody over the reality is knowing is not the issue, it's having it is the issue. Knowing gives you the chance to be empowered to do something. The people have realistic concerns about privacy. Will can this company that you're using, this vendor, protect my privacy with the most intimate information I have? And it's been thought about. It's a concern. There's HIPAA, which definitely protects privacy, and there's protections against being discriminated against with insurance. And I try to let people know all these things have been thought about. I can't promise you what all the things that could happen in the future. I can say in my whole career, I've never heard of someone having this leaked or having been denied coverage because of it. And then I just remind them what you can do with this information, even if you have to take some risk. How does this work out? This risk-benefit ratio is so in favor of testing and knowing.
Well, with me, I was already proactive because of my family history. And what it did was, because not only did I have surgery to remove, I had a hysterectomy, then I had an oophorectomy, and then I had a prophylactic double mastectomy. So I was very proactive because I'm going to do everything I can not to get cancer. So when it did present itself, it was very odd. It was like in the back of my mind, I kind of knew could happen, and it's a very odd feeling because it could happen, and then when it happens, and to tell you the truth, I still say some days, I don't have ovaries and I got ovarian cancer. And when I tell people that, when I told both of them, they were just like, I said, yeah, it's an interesting. So I'd love to hear your stats on that. I think it's 3 to 5% after you've had all these surgeries that you can still have. So of course I still get ultrasounds because I didn't have ovaries and I got ovarian cancer. So I want to make sure I don't get breast cancer with no breast tissue. Yeah.
Yeah. So for me, I kind of knew once I got the counseling that the next big thing that I was going to have to do was determine whether or not I was going to have a prophylactic, double mastectomy, because I absolutely did not want to have cancer again. And so, pretty soon after counseling, I had made the determination with my husband that this was the right thing for me to do. And so I did do that. And it was a weight off of my shoulders because I, didn't want to inadvertently, not have the diagnosis or have it delayed, because again, it took months for me to get the ovarian cancer diagnosis. And so for me, it was like, well, this is a way where, with not 100% certainty, but with a certain amount of certainty, breast cancer is not something that I'm necessarily going to have to deal with. But you're right. You always have in the back of your mind that, anything is possible. And there could be microscopic cells that, aren't detected. But that was the next big thing that I needed to do. And once I did that and recovered, I felt much better about, how I was going to move forward. So,
yeah, the same for me with the mutation of being RAD51C. It would say you have a higher propensity toward ovarian cancer. Already had that.
Yeah.
You have high propensity towards breast cancer, just got that diagnosis. And so the last was colon cancer, which I have not had. But I found, again, through agency, when I do my colonoscopy and we discuss the results, the doctor said to me, okay, well, we'll see you back in 10. I said, no, you'll see me back in 5.
Yeah. Yeah.
Okay, because
Yeah.
I have RAD51C.
Yeah.
And then he was like, oh, let me change the wording in her clinical notes. And so even though I still see it as like the sort of like the Kanye shrug, like, oh, we didn't really find out anything.
Yeah.
I still use it as my calling card when
Yeah.
I'm speaking to new providers who have to interact with me. It's like, no,
Yeah.
you gotta know this about me,
Yeah.
not just what you know about your specialty. You gotta know this about me.
Yeah. Yeah. I'm very good about doing that. I let every single doctor know that I've had cancer and I have a genetic mutation, and do with that what you will, but you will always know that about me. And so
And I always start with, I'm an oddity.
No, I think that's really important, and you all have that in common. I can tell you're all very powerful women and in charge of your care in that way. And I think that's so important to advocate for yourself, because once you have a mutation diagnosed, there's all these decisions that have to be made afterwards. And I can tell you, people can weigh in with their own feelings about what's better, and it can sort of color the recommendations you're getting. And what you really need is someone to sit down with you and tell you what we know, what we don't know, and see how that fits in with what you're looking for. And so even a decision like towards a mastectomy, there's another option. There's enhanced screening because for breast cancer, there are effective screens. And so I have 2 sisters in my practice, and one will decide on enhanced screening and the other decide on a prophylactic mastectomy, and they've both been counseled by me. So I'm just putting it out there. This is what's been shown. So you need that support with people who can give you evidence-based recommendations.
That's just, I guess that's the wildest thing about medicine, is that these bodies kind of do whatever they're going to. And so cancer, my father died of non-Hodgkin's lymphoma, but that was from Vietnam and Agent Orange. So my daughter says to me, she said, Ma, you got me in this genetic valley.
No, that's good.
yeah.
I'll tell you, my family's full of prostate cancer. My father's from Virginia, has 7, he's one of 8 boys. 6 of them developed prostate cancer. My grandfather had prostate cancer, and my father had a sister who I never met, who died of cancer, and we didn't talk about it because my mother always says it upsets the grandparents, don't talk about it. So, but I asked one day, well, how did she present? What was it like? And I found out she presented with a belly full of fluid.
Yeah.
So I'm thinking, I
Ascites.
think Aunt Sally had ovarian cancer. So my brother goes on Ancestry recently, and he did his DNA test, and now he's getting all this death information. He found her death certificate from 1940 something in Virginia, and of course they said stomach cancer. But they used to use that term euphemistically to mean any abdominal cancer. They didn't mean that they had done an EGD and found a stomach cancer. So I'm thinking, I think, so I did genetic testing because I'm like, I think there's a BRCA mutation in my family. So much prostate cancer. I think Aunt Sally had ovarian cancer. I tested negative. But it's possible that I do have something in my family. Like, we didn't always know about 51C. We didn't know. So this is a whole nother story, but I decided, and I'm almost losing my time, but I decided this was the year I was going to do it. I was going to do a webinar for the men in my family, because I'm the one that everybody's talking to, and but I don't share people's information. So this one doesn't know. This one had prostate cancer, that, another. So I'm like, I've spoken to my son about it, but they don't talk about it. So I'm like, I've got some friends who are going to do a webinar for me.
Yeah. And a lot of times you don't know. Like, my brother must have forgotten what my mom passed away from. He thought it was like bowel cancer, he kept saying. And I was
Because
like,
it's abdominal.
Yeah.
And I could say there's a study suggesting that BRCA1 mutation carriers do have a slightly increased risk of uterine serous cancer. So it's possible she had BRCA and it was the serous carcinoma of the uterus, but it's also possible that that's an advanced ovarian cancer, because there's something called primary peritoneal cancer. You can get a cancer, serous carcinoma, that comes from just the lining of the abdomen. So a lot of people were calling ovarian cancer. We really don't know where it started.
Again, it was very perfunctory for me. It was a blood test. It was not something that was really on my mind. It was, oh, that's scheduled just like a blood draw before an infusion, right? And after that blood draw, the test results came in. I sat down with a counselor, and she basically said, you know, we don't have anything that's definite, but at least for me, it wasn't BRCA 1 or 2. When she told me it was rare, I went, yeah, that tracks. I have a rare ovarian cancer. I have a rare ovarian cancer. I have now a rare mutation. I am rare as it relates to triple positive breast cancer because I was stage 0. So everything just tracked at that point. I was just like, okay, nice talk.
That's it.
Yeah.
Yeah.
Yeah, we're done. We're done. Yeah, like I said, for me, it was, you know, I had to have the surgery. And so that was when I first learned that they did the testing of the tumor and told me that I had the mutation. And then there was so much work being done to me. I'm pretty sure that during that process, they did another blood test, but I cannot call it out or recall it. But then I would say once I got out I was in the hospital for about 2 weeks. And once I got out, in short order, I had the appointment scheduled with the genetic counselor, and then we sort of talked about the next step. So I don't know if, you know, I assume that, you know, when you have the surgery and there is a tumor, that they are just testing for all sorts of mutations, correct?
We can talk about it, but not necessarily. You should not assume.
Not assume. So they did that for me, and so I was grateful for that. But yeah, it was they did it because I had surgery and then I had a blood test, and so it wasn't anything that stood out as abnormal to me. It was all new to me, so I didn't know kind of whether or not this was the right protocol or the wrong protocol, but it's kind of what happened. So
With me, as I said, you know, I thank God for the GYN that I had, Dr. Parsons, saying, I don't like the way this looks. And so it was a simple blood test. And but it was when I actually read the registered letter, and it said that you're BRCA1 and I've been trying to reach you. That's when it kind of settled in, like, I'm going to have to be making some decisions. And it was very serious. My daughter Kirsten and my niece Tyler were on their laptops. After they saw me with the letter, I went right to their house. And then they just started looking at the statistics of options, your probability of ovarian cancer and breast cancer. And, you know, I just watched the room just get chilled, you know, and I'm still trying to stay up. And that's one of the things is and I'll say this, when I was first diagnosed, I never asked God why, even though I've had family members close that died. But I did say, because this is how I talk to him, what's up? You know, what's up with this? I've done everything, and how do I get cancer? And just like I'm talking to you, I heard this is going to work together for your good and my glory. So the fact that we're talking about this, it's not only working together for his good, but it's his glory and our good, but this has to go out. We have to make a difference. I don't think that we were diagnosed just for ourselves. I really don't. And I think that I did some research on you, sir, and I saw that you were what you're passionate about. And that made me want to jump through hoops to be here. And so if you would just take it over.
This. I'm really enjoying this conversation because my office staff, they get so angry with me because I'll go behind that door and we just start talking and they're like, Dr. Hogan, you got to move on.
Patients here.
Yeah, because I just learned so much from the patients, and you know, the actual physical part of genetic testing is so easy, right? I mean, what you see in that movie Jurassic Park, you can take a little piece and run the DNA and bring back a dinosaur. That's true. You don't need much to do genetic testing. It's the interpreting the results, explaining to somebody what a variant of unknown significance is, taking into their family history, and when should you take that VUS seriously, when that probably doesn't mean anything, when it's not so clear. In your case, you were at the forefront of tailored, personalized medicine. They were testing your tumor to try to change your treatment, and they should have, or maybe they did explain to you that there were some implications on the back end that you may be carrying a genetic mutation. But that's part of what should happen. You should have a pre-testing counseling, and that says to you, hey, before you do this testing, understand these results may not be definitive, and you may have to change the way you live based on what you're going to find out. And then you need post-test counseling once the results come out. So there's a lot of support for you there, but the actual testing is the beginning. It's the easy part. It's what you do with that information.
Yeah, agreed. One of the hardest things I did was, of course, I told my kids first, but I didn't want to tell my sisters and brother-in-law and my nieces and nephews because I was about the cancer. I was diagnosed on December 8th, and I didn't want to deal. I wanted to do it on the other side of Christmas because we go to my sister Carol's house, and it is games until we most spend the night because we're there so long. And so what I did was we had a wonderful. My daughter and her friend were the only ones that knew about the test and knew about that I had been diagnosed. So the next day, here's Cheryl, who never calls a family meeting, putting in our family chat, where's everybody? And people were still spending the night at Carol's house. I said, okay, I'll come out. And when I started talking, my brother-in-law, Larry, silence, like, how could this happen to you? You've done everything. But telling them this, but the response was first research, and what are you going to do? And just telling folks, and what happened, because I'm so odd, there's a anchor in Rochester, Erica Bryant, that I'm close to. So when I first had my surgery, she did a story on things you can do after you're diagnosed, and then I texted her and I said, Erica, I got a second, I got another segment for you. I've been diagnosed with cancer. So then she did that piece too, and it's difficult, because I know my family, they worry about me, and that's the one thing you don't want, and I'm the one who's always doing everything, and now everyone. I mean, I stayed with my sister Paula for 5 weeks after the mastectomy because I could not move. I was on my back. So I just telling your family is kind of hard, but it's out there now,
Yeah, I have told everyone in my family, and now I'm thinking more. I was thinking recently that I have some nieces who have daughters, have kids of their own. And so how far down the line could this go is sort of my thinking. And I haven't researched it, and I haven't had conversations with them about it yet. So I think that I do want to do that because I have a niece who actually, she did not get testing. She did not want to know. She wasn't interested in any of that. And she has 2 daughters. So I think she's next on my list to really lean into her and have that conversation with her about it. And just make sure, 'cause she doesn't talk to her dad. So I've got to kind of intervene, I think, and continue to have those conversations with them. But I'm just sort of thinking about, how far down the line do you go when you're communicating this and trying to make sure that, at least everyone in your family knows that.
aware.
Yeah, absolutely. And remembers, because, you can tell someone, hey, I have a genetic mutation, and it kind of goes over their head. And so, just circling back, I think, and having a second conversation, if you will, with them about it, I think can be helpful.
Well, for me, I've had the unfortunate opportunity to tell my twins twice, right?
Yeah.
Once when they were 10, and then when they were in the middle of COVID, trying to graduate from high school, right? But in the end, even as an advocate, I still believe that because our data, and I say our in the Black community, cancer rates are going down, but in the Black community, they're still rising. And so we have to have a day to mourn a diagnosis, but then we have to get up and we have to start talking about this because, as they say, representation matters, right? But it also matters when you have the right information. right? There's just so much of your lived story that you can tell. You got to add in some facts.
Exactly.
You got to add in some knowledge. And so our lived experience is so vital. But our advocacy will get us even further with the stats, with better cancer care delivery, with better research, with better folks who are funding research that looks at what's happening to us.
Yeah.
Because the numbers are going up.
Yeah.
But in general, the numbers are going down. So who better to be focusing on right now than Black and brown folks with cancer?
This conversation is reminding me what one of the things that attracted me to GYN oncology as a medical student was taking care of people who, in the midst of their most vulnerable period in their life, were so concerned about everybody else around them. And you three just keep mentioning that over and over, how you were so concerned about the other folks in your life and how this is going to affect them. And I think the medical community is starting to accept this, that it's a lot to ask someone who's just recently been diagnosed, maybe going through treatment themselves, to take the job of notifying the whole family. And so there's this concept of cascade testing now where, the medical community will say, you tell us who in the family you want us to contact. We don't even have to say who it is who's reaching out to them. Just somebody in your family was diagnosed with a genetic mutation. Would you like to be tested? We can mail a swab to you. So what we're finding is that we're getting more people to test by taking this responsibility off of people, because not everybody's got the strength that you three have to take that responsibility on in the middle of your own treatment.
But see, I think that also it goes back to, I don't think it goes back to, oh, well, you had a Black doctor and you still, it's what they've been taught. It's what an OBGYN has been taught, and how they can't make the connection to gynecological cancers, because this is how far you going inside of my body every time you see me, right? And especially for women, whether they're Black women or not, it's a certain point in the relationship with OBGYNs where you've had your babies, you're postmenopausal. It's not as communicated that you still need to see me, right? It becomes this sort of norm of, okay, well, we're really not giving you birth control. We're really not you're not having any more babies. So we drift off between 45 to 60. We drift off from those regular visits.
So with me, I am a little perturbed with my original GYN doctor in New York, female African American, who had my family history every year. I saw her every year, and never suggested genetic testing. I relocated from Rochester, New York to North Carolina, and then moved into South Carolina, and female African American didn't like my family history and immediately tested me. So you got two women, same specialty, treating this patient differently. And my only thought is, how many patients of my first doctor have died? Late diagnosis, stage 3 and 4, because they could have been making decisions whether you want a prophylactic double mastectomy or you want a hysterectomy, or so it really, really bothered me that I could have died on her watch had I not relocated. Yeah.
Did you share that information with her?
I had one conversation after I was diagnosed. I called, I said I needed to talk with her, and all she did was listened, because I think she was thinking maybe the conversation's recorded and she's going to sue me down the line. And it wasn't about suing her. It's about treating every patient like it's your sister, your cousin, your niece. What would you do if that's a family member? I'm not just a patient, I'm a person.
Dr. Hope, can we extend her some grace? Knowing her doctor, knowing that specialty of OBGYN just does so much. It just does so much. I mean,
I think
there's no surveillance for ovarian
it's been
cancer.
an evolution, I'll be honest with you. And when BRCA was first identified,
And when was that?
in the 1990s.
Okay.
So it's not that long. So yes, I'll give you grace to say it hasn't been that long, and new information takes a while to penetrate down throughout medicine. And to be honest, in the beginning, BRCA1 mutation and 2 were identified to be much more common in Ashkenazi Jewish women.
Yep.
And that was said to us in medical school over and over and over. And so without saying, well, other women don't have it, I think you just automatically assume, well, you're only mentioning this type. So that must mean that other people don't have this. And I think there's a lot of doctors who still think, if I see a Black woman, a Hispanic woman, an Asian woman, they're not thinking BRCA. They're not thinking genetically predisposed cancer predisposition. And so I think that times have changed. I can tell you that my colleagues and I did a really interesting study at a past job where we looked at the referrals to our genetic testing over a 3-year period, 2013 to 16, over 1,600 women that were tested. And what we found that was shocking was that white women were more likely to be sent because they had a family history of cancer. So there was no personal history, still an opportunity to prevent the cancer. Black women were much more likely to be sent after they already had cancer. And even if you compared to the people who had cancer when they were referred, the Black women were much more likely to be advanced stage. So when you talk about the need for advocacy, it's saying we're missing disproportionately opportunities for prevention. We're missing disproportionately opportunities for early detection. There's no good screen for ovarian cancer. So this is a mindset that somebody has to be thinking all the time. Abdominal pain, like what you described in your presenting symptoms, are something we should be thinking about ovarian cancer. We should not have somebody 6 months being treated for irritable bowel syndrome before you get a transvaginal sonogram, much less with somebody with your family histories that you guys have shared. So, you know, I give grace that it does take a while to get down, but I do think that the medical community has to hold ourselves to a higher a higher standard that says discoveries that are happening on the forefront have to get disseminated faster.
Yeah, my oncologist, because I had to get a second opinion because I went for 9 months, kind of back and forth to a whole host of doctors before I was diagnosed. And when I finally, met with my gynoc after my surgery, she said, if you had not advocated for yourself, you would be dead. So a light bulb went off, right? And it was just sort of ting, ting, ting. I've got to make sure that I'm continuing to have this conversation with other women who are who have symptoms or who don't feel as though they have agency, and to coach them through that. And so I talk about it all the time, right? And I tell my story all the time because I think representation again does matter. But to have my oncologist say that if I hadn't advocated for myself that I would not be here was huge. And I did go back to my gynecologist and have that conversation with her, and it wasn't to blame her, it wasn't to sue her or anything like that. It was really to just say, hey, she wanted to know what my cancer was. I told her it was a genetic mutation. That seemed to relieve her of any sort of concern that she had, because it was sort of out of her control. Like she could not have figured it out. So but it was really to let her know, hey, these are maybe some things that you should be more attuned to, so that the next patient that comes in doesn't necessarily go through what I go through. Yeah.
I think that we're very misguided just as women. We come into the space of gynecology, and we think that the pap smear is telling us everything that we need to know about all of our reproductive organs. And it really just looks at your cervix. So it's so mind-blowing that, when you ask a woman, what's the status of your ovaries? What do you know about, what's the status of your uterus? Then somebody might say, oh, I know a little bit about fibroids, right? But I think when I said, can we extend some grace to gynecologists, is because they don't practice the prevention of cancer. And so we're putting a burden on someone who has gone to school for a certain specialty, and then you didn't get referred to a gynecological oncologist. You don't want a certain person to do the surgery because they may leave cells behind. It's a lot of stuff in this. And so I feel like it's placing the burden on a OBGYN is just a little
I just
A
want to
little
clarify
much.
one thing. One of the things that changed in the 1990s was OBGYN was considered a primary care specialty. And that was really important so that you didn't need referrals to come see us in the age of the rising HMOs, where as a subspecialist, you were dependent on somebody sending you a referral. OBGYN was identified as, well, that's primary care. So I was going through training at this time, and it changed our residency training. We had continuity clinics that we didn't have to do. We had to learn about vaccinations. We had to learn exactly what you're talking about, health maintenance. We had to learn all those things. So OBGYN is primary care. In fact, for a lot of women, they don't see anybody else. If we're not telling them this, they're not going to hear from someone else because this is all they're seeing. They're going to think I'm anti-OBGYN, but I'm like, no, that's our
That's what I said.
responsibility.
Yeah, yeah.
You cannot shirk that. It is a lot, but that's what you went into. OBGYN is a primary care
Right
subspecialty.
now is in Charlotte, I actually go to Atrium Healthcare. I go to the Levine Cancer Center. I go to Novant Cancer and Health, and I talk to medical students, and I talk to nursing students, and I say when someone walks in with, I had pain from May until December diagnosis. The fact that that pain persisted, you should have said, we need to do another test. And that's where I understand you want to extend grace, and I think that's why I'm talking to medical students, now, because now, can I tell you something? The last 3 medical students I talked to, they said, I would have never thought ovarian cancer with your history. Never.
If someone is unsure about testing, I would let them know is that there is more power in knowing than not knowing, because you then have a potential path forward in terms of how you're going to treat your illness, and knowing kind of what the outcomes could be is going to be more beneficial for you than not knowing. And I just say that from personal experience. Knowing made me feel empowered.
I'm going to look right into the camera. If you have any doubts about what genetic testing can do for your life and for your family's life and your children's life, I'm going to say you can't be selfish. It's not about you. Yes, the information can help you, but it can help your sister and your cousin, your teachers, your professors. It can help. So the next time you're in an appointment, and even if you have a strong family history, or if you're starting to have pain and you want to know a little bit more about it, ask the second and the third and the fourth question. And if it's possible, while you're there in the office, see if you can have a transvaginal ultrasound, especially if it's been prolonged pain. That's an easy test. We hate putting our feet in the stirrups, but hey, if it's going to save your life, get the test.
For me, it's a matter of sitting around the kitchen table and starting to talk about these diagnoses, right? Silence is killing us. And so getting an opportunity to just say, Auntie, you get diagnosed with breast cancer. What does that mean? What is it like? So that every female and male in the family understands breast cancer from your perspective. So then when they have to interact with their primary, they have some sense of what's happening in the family, right? I think that's being able to have those soft conversations first give you a lot more agency and a lot more empowerment when you're talking to your doctor, because at that point, the powers shifts. It's a shift in the dynamic of who has more information. Because I have a cancer survivor at home that can tell me a certain amount of things, but she armed me, or he or she armed me with enough questions that now I can ask you.
Yeah, and I'd have to say, from my standpoint, because I couldn't say it better than you all, because your comments are informed by an experience. But if you don't have a partner on the other side of that desk, if you don't have somebody who you feel you can speak to or who hears you, who can explain things so that you're empowered to make decisions, keep looking. Keep looking. Don't settle for less.
Absolutely. Beautiful. Yeah.